Hi, my name is Lisa Murray. I'm Associate Director of Business Operations at Absorption Systems. And now I'll be speaking about improving assay outcomes, specifically in regard to unique compound properties and how they should be considered for in vitro transporter investigations. I'll also be discussing the interplay of different experimental variables and how it is important to maintain balance when these variables are modified. The unique compound properties that we'll be discussing are nonspecific binding, solubility, and the interplay of these two. SLC transporters are very prominent right now. The FDA and EMA guidelines both recommend evaluation of these uptake transporters during your discovery and development process. In the uptake assay format, the influx rate of a test compound is normalized for protein content and experimental duration. We then compare the rate of uptake in a transfected system versus a non-transfected system to determine the influx rate ratio. If a compound is lipophilic and adheres to the experimental apparatus, then the influx rate may be underestimated, resulting in lack of discrimination between transfected and non-transfected systems. This also results in a loss of assay sensitivity and potential misclassification. The ramifications of false negatives are profound, including adverse clinical events or compromised efficacy. To improve uptake assays, we can include serum protein in the incubation medium. Here is an example of the protease inhibitor lopinavir for HIV, which is known to interact with OATP1B1. In the absence of serum protein, lopinavir is misclassified due to its nonspecific binding. When protein is present at certain concentration levels, we're able to correctly identify this compound as a substrate for the uptake transporter OATP1B1. Likewise, nonspecific binding is an issue for directional assays as well. It's an even more complicated test system with permeability going in both directions, and so may the bias. For bidirectional studies, compound permeability is determined in the apical to baselateral direction and in the baselateral to apical direction to determine the apparent permeability or PAP value. PAP in the B to A direction is compared to the A to B to determine efflux ratio. If compound permeability is underestimated due to nonspecific binding, then the efflux ratio may also be underestimated, resulting in reduced sensitivity of the test system. Additionally, the bias is for lower recovery in the A to B direction versus the B to A direction. This could potentially result in an exaggerated efflux ratio. Therefore, you can either obtain false negatives or positives in the directional format. There are a variety of techniques for alleviating nonspecific binding in the directional format. Pre-incubation of the test compound in the donor compartment helps to maintain the level of test compound in the donor available for transport throughout the assay duration. Including 1% BSA in the receiver compartment mimics more physiological sink conditions. We can also assess mass balance by collecting test compound in the donor, receiver, and intracellular compartments in order to get a more accurate determination of efflux ratio. Furthermore, we can modify our calculations. Instead of a traditional PAP calculation, we can utilize an interval approach where we correct for the loss of compound from the donor compartment due to nonspecific binding. Here's a dramatic example of a test compound before and after implementation of these procedures to alleviate nonspecific binding. CACO2 A to B PAP was only about 4 for this compound before these procedures were implemented. The recovery of this compound was approximately 25% due to severe nonspecific binding. After we implement these procedures like pre-incubation and interval calculation, the permeability of test compound is accurately measured at about 34. In our test system, in order to qualify as a highly permeable test compound, the PAP must be greater than that of a co-dosed internal standard, which has a PAP value of around 4 to 5. Implementing these procedures enable accurate PAP classification and actually reveal that this is a Class 1 compound. This is only uncovered when these procedures are taken. Now we'll discuss another common problem, solubility. It's critical when you run these in vitro transporter studies to use therapeutically relevant dose concentrations in order to obtain meaningful results that can translate into your clinical strategy. For transporter inhibitor assessment, concentrations are based on I1 and I2. I1 is based on the mean steady-state plasma Cmax at the highest clinical dose. I2 is the theoretical maximum GI concentration after oral administration, and it's based on the highest dose strength dissolved in 250 mLs. You take the higher of 10 times I1 or 1/10 of I2, and that is your target concentration for your transporter study. So most compounds have, per se, a dose of 250 milligrams, molecular weight of 500. So the target concentration would be 200 micromolar, which is often hard to achieve based on solubility. If you don't have this, it can invalidate the utility of the in vitro transporter assay. So what is the solution? First, it's imperative to confirm the solubility and deconvolute other parameters that may be contributing to low recovery, like nonspecific binding or instability. To confirm transporter-relevant solubility, we've come up with a technique for doing this based on our experience and our own research. First, we perform a kinetic solubility assessment starting from organic solvent, and then we confirm that the preparation of the material is reproducible to ensure that we always achieve the target concentration. If the target is not achievable, there are still solutions, such as qualified excipients, that can be used to enhance your compound solubility. Some of those are listed here that we have qualified previously in-house and are known not to compromise the integrity of cell monolayers or impact transporter function, making them ideal for in vitro transporter assays. One of the prevailing themes of this discussion has been that if you modify one parameter of an in vitro transporter assay, it is imperative that you maintain balance in other parts of the experiment. For example, you must consider whether introducing excipients will compromise tolerability, in which case you may need to truncate assay duration or influence on other efflux or uptake transporters. Here's an example of an excipient used to enhance solubility of a test compound. On the right are two IC50 curves for digoxin and cyclosporin A. The excipient itself does not inhibit efflux of digoxin. However, when known PGP substrates are evaluated with this excipient at 0.05%, there is an apparent diminished activity of PGP in MDR1 MDCK cells. However, in all of these cases, there is sufficient activity remaining to still qualify these as PGP substrates. Therefore, as long as your conditions are qualified and evaluated for potential implications, this is acceptable. And in conclusion, when you modify certain parameters of an in vitro transporter assay, it's imperative that you take others into consideration. All of these are interrelated. For example, when you enhance solubility or alleviate nonspecific binding, you must be cognizant of tolerability and assay sensitivity. Thank you.